Welcome to another episode of Cutting the Boards. In today's episode, we're going to talk about head, spine, and maxillofacial trauma. One of the most high-yield concepts from this lesson is going to be calculating in GCS. As you can see, there are three components of a GCS. There's eye openings, which is a maximum of 4, verbal, which is a maximum of 5, and motor, which is a maximum of 6. You will be expected to calculate this on the test. For somebody who's intubated, the maximum score that they can have is an 11T. And then the maximum score for any patient is going to be a 15. The minimum score is at 3. Best prognostic factor of a GCS is going to be a motor component, and then a GCS less than 8 is an indication to intubate and also an indication for an ICP monitor. So you're going to be expected to know this not only for your ABSITE, but in the trauma bay with a hectic patient. It's good to kind of memorize these different components of the GCS and be able to calculate it quickly. There aren't really many high-yield topics when it comes to head trauma, but one that's important to know is the difference between an epidural and a subdural. So an epidural is going to be caused by arterial bleeding from the MMA, and clinically how this is going to show is your patient's going to have a period of loss of consciousness, followed by a period of being lucid and awake, and then followed by deterioration after the pressure increases on the brain. On a CT, you're going to see a lenticular deformity. Treatment for this is typically going to be an embolization followed by a cranie to evacuate and then release the pressure on the brain. For a subdural, on the flip side, is caused by tearing of a venous plexus that crosses the dura and arachnoid. On CT, you're going to see a crescent-shaped deformity. An intracerebral hematoma is usually caused by blunt force trauma to the frontal or temporal lobes. And then an important aspect of trauma is going to be to remember that hypovolemic shock cannot be caused by intracranial bleeding alone. And if your patient does have evidence of hypovolemic shock, you need to look for other sources of bleeding. And this is an image to better demonstrate the difference between an epidural, a subdural, and then an intraparenchymal bleed. So for somebody with a significant head trauma, you may see elevated CPP or asked to calculate a CPP for somebody with a bolt monitor, say in your ICU. So CPP is cerebral perfusion pressure, and this is equal to mean arterial pressure minus the intracranial pressure. Reduced cerebral perfusion pressure can cause a secondary TBI, and this essentially means less blood flow to the brain, meaning less oxygen delivery. ICP, or intracranial pressure, a normal value is around 10, greater than 20 typically needs treatment. So if you want a CPP greater than 60 in your ICU, some things you can try is giving volume impressors to improve your MAP. You can give sedation and paralysis to decrease your ICP. You can give hypertonic saline and mannitol to decrease intracranial pressure. You can also do hyperventilation for vasoconstriction, but this is controversial as well. In a question stem, you may see the symptoms of bradycardia, hypertension, altered respirations, and this should clue you into Cushing reflex, which could be a clue that this patient is about to have impending brain herniation. Some of the clinical signs to look out for: dilated pupils mean that the ipsilateral temporal lobe is putting pressure on cranial nerve 3, causing the dilation. In a basal skull fracture, you can also see periorbital ecchymosis, and that clues you into an anterior fossa fracture, whereas in a basal skull fracture with battle sign or mastoid ecchymosis, that's more so a middle fossa fracture, and you can consider a cranial nerve 7 injury in that case. For skull fractures, with basal skull fractures, you want to avoid nasotracheal intubation, and then temporal skull fractures can also injure cranial nerve 7 and 8, so something to keep in mind. Next, I want to talk about spine injuries, so some notable ones with different names. So a C1 burst fracture is called a Jefferson fracture caused by an axial loading injury. Treatment for this is going to be a C-collar. A C2 hangman's fracture is caused by distraction and extension. And then treatment for this is usually traction or a halo. C2 odontoid fracture, there's 3 types. Type 1 is stable versus type 2 and 3 are typically unstable. Type 1 is above the base, type 2 is at the base, and then type 3 extends into the vertebral body. Clinical clearance of a C-collar, not really something that's testable, but something that comes up on rounds and in the hospital. These patients, to clear their C-collar, cannot have a distracting injury, cannot be intoxicated, cannot have neurodeficits or tenderness, and must be a GCS of 15. If you're unable to clear a C-collar clinically, you can also clear it via MRI C-spine to evaluate the columns for stability. Which brings me to my next point of there's 3 columns of the thoracolumbar spine, and greater than 1 indicates a column injury, which is deemed to be unstable. If you see calcaneus fractures, and you may see it in a question stem, you always have to consider a spine injury because the amount of force and pressure that is needed to cause a calcaneus fracture could easily have caused a spinal fracture as well. When we think of the workup or intervention for spinal fractures, we want to get an MRI to check for ligamentous injury, if any deficits or pain associated with the injury. Emergent spinal decompression, some of the indications are fracture not reducible with distraction, an open fracture, soft tissue or bony compression of the spinal cord, progressive neurologic dysfunctions. And then something of note, and this will come up on rounds, is that spinal shock is referring to sensory or motor deficits but not hypotension. So that's something to keep in mind. When it comes to maxillofacial trauma, it's important to know the Lafort classification, as you'll see it in the hospital and then rarely on the boards. You can see in the bottom right there's a graph which kind of goes over the different types of the fractures, and then you can see how it corresponds to the injuries on the right in the picture. For a temporal bone fracture, be wary of a facial nerve injury. Be cautious of CSF leak with an ethmoid fracture. For an orbital blowout, your patient will have impaired upward gaze. Malocclusion is usually a good indicator of injury, so something easy to test on your patients. And then in these patients with facial fractures, it's always important to consider a CTA. It's an easy way to evaluate the blood flow in this area, and then also always evaluate the cervical spine for any injury. I really hope you enjoyed this high-yield review of brain, spine, and maxillofacial trauma. If you have any questions, feel free to put them in the comments, and as always, study smart, stay consistent, and your future patients will thank you for it. I'll see you in the next video.